Hey everyone and welcome. Today we're unpacking a condition that's often ominously called the silent thief of sight. We're talking about primary open-angle glaucoma, or POAG for short. It's this fascinating but absolutely serious condition where pressure inside the eye just slowly, secretly builds up, and it silently threatens our vision. In this explainer, we're going to break down exactly how this happens. We'll look at how medical professionals put on their detective hats to catch it, and most importantly, we're diving deep into the modern strategic defenses used to treat it. We'll really be focusing on the diagnostic criteria and comparing the latest laser therapies right alongside traditional eye drops.
Okay, let's dive right into this. Here's our roadmap for today. We'll start with the anatomy of glaucoma, move into spotting the silent thief, open up the diagnostic toolkit, and then hit our main management strategies: first-line laser therapy and next-line medical eye drops.
All right, Section 1, the anatomy of glaucoma and aqueous humor drainage. Let's get into it. So, to really understand this disease, we first need to understand the eye's plumbing system, specifically how it handles the fluid called aqueous humor. Just imagine a sink, right? The drain looks completely open and unblocked from the surface. In the eye, this means the peripheral iris is perfectly clear of the trabecular meshwork, which is the main drainage area. So the angle is quote-unquote open, but deep down within that drain, the pipe itself is functionally resisting the flow of water. And because the aqueous humor just can't drain out as fast as it's being produced, the intraocular pressure, or IOP, starts to rise. And that pressure buildup, that's what ultimately causes an optic neuropathy.
Now, you might be wondering who's actually most at risk for this functional resistance. Well, the risk jumps dramatically as we age. It actually affects less than 1% of people under 55, but that shoots all the way up to 10% for folks over the age of 80. Genetics play a massive role here too. If you've got a first-degree relative with open-angle glaucoma, your chance of developing it is a whopping 16%. Some other really significant risk factors include Afro-Caribbean ethnicity, having myopia, so being nearsighted, hypertension, diabetes mellitus, and the use of corticosteroids.
Moving on to Section 2, spotting the silent thief, its insidious presentation.
So, because POAG is so insidious, meaning patients literally don't feel those peripheral blind spots forming, it's super often caught during just routine eye exams, which is, by the way, a great reminder to keep up with your optometrist appointments. But if the patient can't feel it, how on earth do doctors see it? Well, they put on their medical detective hats and look right at the back of the eye using a technique called fundoscopy. They have this very specific checklist. They're looking for optic disc pallor, which is a sign of optic atrophy. They look for something called bayoneting of vessels, which is wild. It's where the blood vessels literally look like they break and disappear as they dive into a deep optic cup, only to reappear at the base. They're also hunting for cup notching, usually at the bottom where vessels enter the disc, and tiny disc hemorrhages, but the biggest, most prominent sign they look for, that's optic disc cupping.
And that brings us straight to this absolutely crucial number, 0.7. See, a normal cup-to-disc ratio sits somewhere between 0.4 and 0.7. If that ratio climbs above 0.7, there's a problem. It means the optic cup is actually widening and deepening. Why is that happening? Because that increased pressure we talked about earlier is literally causing an irreversible loss of the optic disc substance.
All right, let's turn to Section 3, the diagnostic toolkit used for investigating POAG. Finding and diagnosing this condition follows a really highly structured three-step chain of command. Step 1 is the optometrist. They are the absolute critical first line of defense here, responsible for case finding and making that provisional diagnosis during a routine exam. Then we hit Step 2, the general practitioner, or GP, who facilitates the formal referral. And finally, Step 3. This is where the specialist, the ophthalmologist, steps in to run a full battery of investigations and lock in that final diagnosis. Now, when you finally get to the ophthalmologist, they open up a very specialized toolkit. They're going to use automated perimetry to formally map out your visual field. They'll use a slit lamp with pupil dilatation. That's to get a crystal clear baseline look at the optic nerve and fundus. They'll also measure your exact intraocular pressure using applanation tonometry, check your central corneal thickness, and use something called gonioscopy to assess the depth and the configuration of the anterior chamber. All of this data, the whole shebang, helps them assess the risk of future visual impairment. And they factor in everything: your IOP, your corneal thickness, and even your life expectancy.
That brings us to Section 4, first-line laser therapy and lowering eye pressure.
Once that diagnosis is confirmed, we shift gears. We go from detective work straight into strategic defense. And the ultimate goal of that defense is hitting a very specific threshold, 24 millimeters of mercury. What's really interesting here is this exact number. According to the NICE guidelines, if a patient's intraocular pressure hits 24 or higher, doctors don't just wait around. Proactive intervention is immediately recommended.
And this brilliantly illustrates the modern approach to that intervention. Right now, current guidelines recommend 360-degree selective laser trabeculopathy, or SLT, as the go-to first-line treatment. By using a laser to actually improve the eye's drainage, you can significantly delay the need for eye drops. It even reduces the chance that you'll need drops at all, though, a second laser procedure might be necessary down the road. On the flip side, you've got prostaglandin analog, or PGA eye drops. These actually used to be the default first step, but now they are considered next line. Why? Well, they require strict daily administration and they come with some pretty notable adverse effects. So the shift in medical management is super clear here. We are moving away from daily maintenance and leaning heavily into a proactive, procedural defense.
Let's look at Section 5, Next Line Medical Eye Drops and Medical Management. So what happens if the laser therapy just isn't enough? Or maybe its effects kind of wear off over time? Well, that's when pharmacology steps in as our vital secondary defense. Let's really look at the different classes of medications because the choices here are surprisingly complex. The first drop doctors usually reach for is a prostaglandin analog, like latanoprost. It's given once a day to increase that fluid outflow. But get this, it has a really surprising side effect. It can actually cause brown pigmentation of the iris and literally increase your eyelash length. No joke. If that doesn't work, they might look at beta blockers, like timolol, which reduce the actual production of aqueous fluid. But, and this is a big but, these have to be entirely avoided in patients with asthma or heart block. Then we have sympathomimetics, which both reduce production and increase outflow. The catch? They can cause hyperemia, so really red eyes, and you absolutely cannot take them with certain antidepressants like MAOIs. Next up are carbonic anhydrase inhibitors. These also reduce fluid production, but they can trigger systemic sulfonamide-like reactions. And finally, miotics, like pilocarpine. These increase outflow, but can leave patients dealing with a constricted pupil, headaches, and blurred vision. As you can see, balancing the mode of action with these potentially severe side effects requires some incredible precision from the doctor.
Now, in the event that both those first-line laser therapies and the next-line medical eye drops fail to sufficiently lower the pressure and stop that vision loss, we do have one final line of defense: surgery. Specifically, a procedure called a trabeculectomy. Doctors might consider this for those really stubborn, refractory cases, basically going in to physically create a brand new drainage channel for the eye. So, as we wrap up this explainer, we're really left looking at a fascinating paradigm shift in glaucoma management. With proactive laser therapy now totally leading the charge as our primary first-line defense, are daily, side effect-heavy eye drops slowly becoming a thing of the past, or will they always remain an essential backup? It is an absolutely incredible time for innovation in eye care. Thank you so much for joining me today to explore this topic. Keep learning, and I'll catch you next time.